A very good evening to all of you. Myself, Dr. Prateek Garg, your ENT tutor. We will discuss about acoustic neuroma. Let's start with the question. A 70-year-old male patient presented with the left side sensorineural hearing loss and tinnitus. On examination, there is loss of sensation of posterior superior part of external auditory meatus. His MRI is shown below. The most probable diagnosis is. So let's look out at the question. 70-year-old male patient. That means the patient is in elderly age group. Presented with the left side sensorineural hearing loss. That means there is a pathology affecting the hearing and it is sensorineural. That means middle ear or external ear are not affected. So maybe the cochlea or the retrocochlea, that is the auditory nerve or the part of the cochlea may be affected. And tinnitus. So SNH loss plus tinnitus both may get affected in the pathologies of inner ear or the auditory nerve. On examination, there is loss of sensation of posterior superior part of external auditory meatus, or we can say external auditory canal. So we all know the external auditory canal, the posterior superior part of the external auditory canal is supplied by the facial nerve. The sensory supply is by the facial nerve. So that part, that sensory supply of the facial nerve is also affected. That means my pathology is not in the cochlea, because any cochlear pathology will not directly affect the facial nerve function. Now MRI is shown below. So look at the MRI, we can see a whitish mass at the level of CP angle, that is a cerebellopontine angle. This is my cerebellum, this is my bones. So at the CP angle we can appreciate a big mass. So most probable diagnosis is, and my options are 4. Otitis media with brain abscess. We know it is not an otitis media because middle ear function seems to be normal, because examiner has only pointed about sensorineural hearing loss, and plus if there is an abscess there should be fever or some sort of paralysis, but it's not there. So option A seems to be incorrect. Then comes a cerebral glioma. By looking at the location in the MRI, we know it is not a cerebrum pathology. And again, cerebral glioma will not present as a sensorineural hearing loss or tinnitus. Okay. So option B seems to be incorrect. Third option is acoustic neuroma. That is a neuroma of the acoustic nerve, that is the auditory nerve. So we all know acoustic neuroma is the most common tumor present at the CP angle and mostly present in the elderly age group. So it seems to be correct answer. The fourth option is ependymoma. Again, this will not present as an sensorineural hearing loss or the tinnitus. So acoustic neuroma is the only disorder given in the option which is somewhere related to the ear. Okay. So let's study what is acoustic neuroma. It is the most common tumor of the CP angle. Again, the examination point of view important. That it is a benign lesion. It is not malignant tumor. It is a benign tumor, but it grows slowly at the level of the CP angle, may grow into the internal auditory meatus, that is the IAC, and it is again the non-capsulated tumor, that is the uncapsulated tumor. Mostly the acoustic neuroma present unilaterally, not bilaterally. But suppose there is an NF2 gene mutation, that is a neurofibromatous disease. If this is associated with NF2 gene mutation, then it may be bilateral tumor. Otherwise, acoustic neuroma is a tumor which presents unilaterally, that is over the one side, affect the elderly age group, that is a 60 to 70 year of age group most commonly. Plus, it is a benign locally invasive tumor, not a malignant tumor. And it has been studied that it arises from a zone which is known as Obersteiner-Redlich zone. What is this zone? It is a transition between the central myelin and peripheral myelin. So we have to remember it arises from Obersteiner Redlich zone. Again, the examination point of view is important. All these points which we are discussing, that is unilateral presentation, affect the elderly male patients, mostly it is a benign. It has been already been asked in the exam in multiple times in different forms. And most commonly, the inferior vestibular nerve is the nerve from which this tumor arising. Just try to remember this diagram where we can see, you know, the Bill's bar, then falciform crest and all these. So there lies the superior vestibular nerve, then lies the inferior vestibular nerve, and above lies the facial nerve. So this acoustic neuroma is arising from, this is my cochlea nerve. This acoustic neuroma is arising from inferior vestibular nerve. Most commonly, that is also known as singular nerve. Very, very important. It has been asked multiple times. Now, what are the clinical features? By looking at the question which we have already discussed, we know that mostly present with the sensory neural hearing loss, which is unilateral. Tinnitus is there. There is no vertigo. Why does there no vertigo? We all know the vertigo happens because of the semicircular canal or the vestibular pathology that is a part of the inner ear. Whereas in acoustic neuroma, it is a CP angle tumor. So semicircular canal and this my vestibule, that is a utricle and sacule, are basically spared. So that's why the patient will not have any vertigo. He will present with the hearing loss, that is sensory neural plus tinnitus, and there will be one sign positive which is known as Hitzelsberger sign. This is the hypoesthesia or decreased sensation in the posterior superior region of the external auditory canal. It happens because of the facial nerve affected in the acoustic neuroma. We all know the facial nerve also arises at the level of the cerebellopontine angle. We know, we have discussed in the facial nerve anatomy that at the level of the bones of the CP angle, it takes a turn around the abducens nerve and then comes out from the brain and enters into the internal acoustic meatus. So at the same place, this auditory nerve, vestibulocochlear nerve, is also there. So any tumor of the vestibulocochlear nerve may affect the facial nerve. And the sensory, we all know that any of the mixed nerve, if there is any paralysis, so firstly the sensory functions are lost and then the motor functions are lost. So in beginning, the facial nerve sensory supply will be lost, leading to hyperesthesia in the external auditory canal, posterior superior quadrant. And again, also the fifth nerve, that is a trigeminal nerve, is the nerve which is earliest or the firstly affected nerve in acoustic neuroma. Again, it has been asked multiple times. You can see how many times it has been asked in the last few years. So in acoustic neuroma, trigeminal nerve, it also runs in close proximity at the level of this auditory nerve. You can recall the diagram of the middle ear where we can suppose this is my petrous apex of the temporal bone. This is my petrous part of the temporal bone, and here lies the this middle ear, then comes the inner ear part. So trigeminal nerve runs in close proximity to the system. That's why it is the first nerve to get affected earliest. And how we can detect? There will be decreased corneal sensation. So in acoustic neuroma patient, if it try to touch one paper over the cornea, patient will not feel any sensation. So that is the reduced corneal sensation because of the fifth nerve affection. And it also tells that tumor size is more than 2.5 centimeter. Now the next question is acoustic neuroma of 1 centimeter diameter. The investigation of choice for its diagnosis is, the option are contrast enhanced CT scan, gadolinium enhanced MRI, SPECT and PET scan. So the answer is MRI. Any of the CP angle tumor, the best investigation is MRI because it's a soft tissue lesion. Why not PET scan? PET scan generally used to reassess the cancer patient after their therapies like the radiotherapy or chemotherapy to find out any residual tumor. Okay, so MRI with the contrast is the investigation of the choice for this acoustic neuroma or intracanalicular tumor. If the examiner want to ask what is the investigation audiological, if we talk about the audiological investigation like the audiometry or the BERA or the OAE, so then the BERA is the investigation of the choice. So the BERA, and if look at this diagram, there will be delay in the wave 5 because there will be decreased transmission of the sound energy. So when we do the BERA, there will be delay in the wave 5. So that is the best investigation or investigation of choice for the audiological investigation. Radiologically, it is gadolinium enhanced MRI, and on MRI we can appreciate the eyes cone appearance. Now, what is the treatment? Treatment of acoustic neuroma is surgical excision. That is the treatment of the choice. There are various methods like the middle cranial fossa approach or the translabyrinth approach. There are some few other approaches also, other means also, like the gamma knife or the cyber knife, which are used, which are some of the latest lesion. Radiosurgery can also be used for the small tumor which are less than 30 cc in size. Now there is a comparison if you use the middle cranial fossa approach or we use the translabyrinthine approach. So this middle cranial fossa approach, it is suitable for smaller lesions. What are the advantages? Advantages are firstly, it preserves the hearing because the hearing system is not affected if it took the middle cranial fossa approach. Secondly, the facial nerve palsy chances are also less, so facial nerve function preservation is high, and CSF leak risk is low. The only disadvantage, or we can say the comparable disadvantage, is we have to retract this cerebrum, you can say. So there will be retraction of the temporal lobe or cerebrum, you can say. What if we talk about the translabyrinthine approach? This approach we can remove tumor of any size. If tumor is very big, then we have to go through the translabyrinthine approach. But the disadvantage is, firstly, there will be no preservation of hearing. We have to approach translabyrinthine approach itself means that firstly drilling out the labyrinth, that is a inner ear, and then we enter into the internal auditory canal or at the CB angle. So it destroys hearing. Facial nerve chances injury are also known, and CSF leak risk is high.